No. I should have. But we should have put in questions about nature.
Oh, yeah.
I'm not gonna explain it, but. How do you feel?
Also, the fact that the one so annoyed
Good afternoon, everyone. My name is Tim Maul. I'm a perfusionist and a senior research scientist at Nemours Children's Health in Orlando. And the topic I'll be presenting today is on hemolysis in pediatric extracorporeal life support. By way of disclosures, I am a consultant for MC3, Fresenius, and HEMOQ, but these do not have any impact on the content of my presentation. So according to the ELSA registry data from about the last 4 years, hemolysis is documented at a rate of about 11% in the pediatric patient population. While this is not the most common complication that we see on ECMO, it does represent a greater than 20% survival drop from overall expected group survival. And this is not the case when we look at the same data for adult respiratory or adult cardiac ECMO. Similarly, when we look at the rates of oxygenator failure or circuit change for thrombotic reasons, again, we see a much higher incidence of neonatal and pediatric ECLS complications, and it is really the neonatal group that is impacted the most. So my interpretation of this ELSA data is that despite all of the improvements in our equipment, neonatal and pediatric ECLS are at the highest risk for impacts for device-related complications. And what are the reasons for these complications to be more prevalent and increase mortality in children? There's a lot of studies that have tried to tackle this problem. Some say it's the roller pumps that we used and still continue to use. Some say it's the oxygenators that we're using. Others say it's the cannula. More recently, centrifugal pumps have been getting a lot of attention. And sometimes it just seems like everything from anticoagulation to our general ECMO practice in general is the cause of our troubles. So my goal here today is to share a portion of kind of what goes on inside of my head without looking like this. And I want to start with a really interesting paper that was published late last year about what happened in one institution when a change was made from their 1/4-inch roller pumps to a 3/8-inch centrifugal pump in their neonatal patient population. These 3/8 centrifugal pumps seem to have proportionally more major thrombotic events. And when they switched to 1/4-inch centrifugal pumps, it seemed to be not as severe. In fact, it dropped to 0. And when they showed some oxygenator dissections from their major thrombosis events, you can see that there's a dark thrombus appearance on the venous face of the oxygenator. And these occurred in only the first few layers of fiber. The authors hypothesized that the turbulence or heat-associated activation of the hemostatic system was the reason for this phenomenon. And they thought this because there's, when we go from 1/4-inch oxygenators to the 3/8 centrifugal pumps, there's a step up and step down. in the connectors, you might have a bigger pump. But the reality is I don't think it's really related to the hemostatic system. And the reason I don't agree with this is that nearly 10 years ago, data was presented at a ECMO conference in Houston, Colorado, by one of my dear colleagues about an issue that we were starting to see at that time with the Rotaflow oxygenators and the PD quadrox oxygenators, Rotaflow pumps and PD quadrox oxygenators. And we were seeing the same phenomenon, what we call clogging oxygenators. We'd see an oxygenator that was running fine, and then all of a sudden it just went from, delta P's were over 100, pumps shut down, the blood flow rate was 0. And so here you can see a series of 3/8 centrifugal pumps with these quadroxes using fresh human donor blood heparinized to cardiopulmonary bypass levels. So this is ACTs well over 350. And what they did for this study was they actually put an arterial line filter, the thing that we use in bypass to prevent clots from going to the patients, in between the pump and the oxygenator. And lo and behold, you could see that the arterial line filter was the thing that was clogged up, not the oxygenator. So this started to put some dents into the ideas that we were seeing just an acute thrombotic event in these clinical patients. And they even took it a step further and looked at scanning electron microscopy of the clots, or what they thought was clot. And you see on the left, this is what they saw, which is this smeared cellular debris, which if you contrast it on the right with an example of what a clot would look like under scanning electron micrograph, you can see that they're not anywhere near close. So it's basically cellular debris. And so that leads us to the conclusion that the pumps must be somehow damaging the cells. But this was the Rotaflow. These are the 2nd generation pumps. These are all being used by our adult colleagues. They were great, much better than the old BP40s. And the adults weren't having this problem. So what did we miss? And so when I saw that presentation, I went back to my institution and started looking through our data. And so I looked at about 156 ECMO runs over 10 years. And in our institution, we utilize 2 circuit sizes, a 1/4 inch and a 3/8 inch circuit size. In the 1/4 inch circuits, we either used a roller pump or the PD mag centrifugal pump. And in our 3/8 circuits, we either used a roller pump in the Centromag or the Sorin Revolution. And when I divided the data by circuit size, I found that the 1/4 inch circuits had more hemolysis problems than the 3/8 circuits, but any of the hemolysis was not related to the pump itself. So within the 3/8 circuits, all the pumps behaved about the same, roller and 2 centrifugal pumps. And within the 1/4 inch circuit, they behaved the same. The roller and the PD mag both had higher hemolysis levels, but they were still equivalent to each other. And so that to me told me that there was another factor at play other than pump type. And I'll come back to that later. And so in trying to research what I think was going on and some recent data that's come out, I think the problem is it's how we're using a lot of these centrifugal pumps. So this study from 2018 was done to examine newer types of oxygenators, the EOS, which is a long pass hollow fiber oxygenator from LivaNova. And with a Centromag pump. So basically they're asking the question in this study, does this pump cause hemolysis? Can we use this combination of pump and oxygenator for good effect in pediatric ECMO? And so they did an in vitro study over 24 hours looking at the free hemoglobin generation at 5 liters per minute, 3 liters per minute, and 1 liter per minute. And you can see in the graph that the curves appear all the same. That there's very little hemolysis that's generated more in one group than another. And so the authors concluded that, this pump appears to be similar to this other pumps that they've seen, and everything was great. But the problem when you look at this kind of data is that you're actually not comparing apples to apples because of the flow rate. So when we test these devices preclinically or to send data to the Food and Drug Administration to get one of these devices labeled for use, we use something called the normalized index of hemolysis to explain what the free hemoglobin generation is in our in vitro setup, normalized by the volume of our setup by the flow rate and how long we were testing. And so when you do this calculation for the data presented by Hodge, you actually can see that as you walked yourself from 5 liters per minute down to 1 liter per minute, the hemolysis was actually increasing. In fact, it increased over 6-fold from 5 liters down to 1 liter. So we apparently are actually seeing higher hemolysis at lower flow rates. And why would that happen? And the reason is because the pumps are inefficient at low flow rates. So when any mechanical engineer designs a centrifugal pump for water pumping or petroleum pumping, they have to pay attention to what the pump is designed to do. So they have a specific envelope that they want the pump to work at. And so one of the things they look at is the hydraulic efficiency of their pump, which is a ratio of the power output, which is basically flow rate and the pressure drop across the pump, divided by the power input, which is the torque and the pump speed. And so they design their pumps to operate within 10% of their best efficiency point. So if you operate these pumps outside that zone, the pump's actually going to fail more quickly. So instead of having a water pump that lasts for 10, 15 years, you actually can have a water pump that fails within a year. And of course, the city's not going to like that. So they want you to design and use pumps for the purpose for which they're intended. We never think about this really in medical devices. And so there's a really good paper in 2019 that explained that when you take these adult centrifugal pumps, and in this case, they took a DP3, a Rotaflow and the Sorin Revolution, and if you drop their flow rates from where their efficiency zone is, which is over 4 liters per minute, down to half a liter a minute, you can see that the hydraulic efficiency drops. It starts to drop exponentially. And when that happens, the drop in efficiency is caused by what we call secondary flows. So this is fluid movement within the pump itself that is not contributed to forward flow. So fluid is moving around inside the pump, but it's not leaving. And again, as you see, as you go below 2 liters per minute in these pumps, you start to see this exponential rise in what they call recirculation or secondary flows within the pumps. And if you calculate a hemolysis index based on these computational fluid dynamics, you all will see that you also get this exponential rise in the potential for generating hemolysis as you drop below 2 liters per minute in all of these pumps. And all 3 of these pumps are used widely in adults and they have really good outcomes. But when you operate them below their efficiency points, you're going to generate more hemoglobin. The authors from that 2019 study followed that up in 2021 with a bench study comparing the DP3 to between an in vitro analysis, which is their silicone stuff, which is computational fluid dynamics, and an in vitro bench test. And they found exactly the same thing. When they dropped themselves from 4 liters per minute down to 1 liter per minute in the computational models, they had a 2.5-fold increase in hemolysis. And on the bench, it actually was worse. It was about 6.2 times. And this actually matches what we were seeing in that earlier paper from Hodge, where as you drop from 5 liters a minute down to 1 liter a minute, you saw about a 6-fold increase in the normalized index of hemolysis. So again, this is telling us that operating adult pumps at pediatric flow rates is not exactly gentle for their blood, even though we feel like we're being gentler because we're not having as high RPMs, we're not pushing as much flow through these devices. But most of the manufacturers don't give us these efficiency data. In fact, you have to really dig through the literature to even find it. And so we don't know when we're operating our pumps really inefficiently. And so I think that's something that I would hope that manufacturers will change as we begin to speak to them and tell them what we need out of them. But in the meantime, we can try to take some advantage of some of the data that we have every day that we know about these pumps. And if you recall that we said the hydraulic power or hydraulic efficiency is related to the power output over the power input. And there are 3 parameters actually that we know on a regular basis for our pumps, and that is the flow rate and the pump speed. And if we use those 2 pieces of information, can we actually figure out when we're operating at an unsafe level? So one of my colleagues in the University of Pittsburgh Medical Center and Children's Hospital looked at this in their NICU. So they have a CentroMag or PediMag pump with a pediatric quadrox, and they looked to find, is there a ratio of the basically RPMs to flow rate. They took that and kind of inverted it, but RPMs to flow rate that would signal that they're about to have some hemolysis problems. And so they did this for a plasma-free hemoglobin greater than 50 milligrams per deciliter. And they found a ratio of 12,000 revolutions per liter in their PediMag pumps, which seemed to be the cutoff for being able to predict that within 6 hours, they would see a free hemoglobin level over 50. So I took their idea and I applied it to our institutional data with PediMag pumps, a CardioHelp, which was used between neonates and older patients, and the CentroMag pump. And I couldn't quite get it to hit the exact 12,000 ratio that Dr. Kiger had at Children's in Pittsburgh. But if I use their number, I still was able to determine that, statistically, that our patients were more likely to have free hemoglobin greater than 50. I did find sort of a converging value for the CardioHelps and the CentroMags of about 2580 and 1191 RPMs to liters for those ratios. And as an interesting anecdote, just this week, my colleague in Delaware called me and said, hey, we've got a neonate, 2.5 kilos, it's on our CardioHelp, and our free hemoglobin's up over 120 milligrams per deciliter. What should we do? And I suggested to them that they need to open the shunt that they normally use for their small patients up a little bit more to try to achieve this RPM to flow ratio. And so they opened up the shunt more in the patient and achieved a ratio of about 2,300. And they called me back just this morning and said that the free hemoglobin is now down to 60. So I think that this actually will be a viable option for us moving forward. Still need a little bit more data to try to narrow in and make sure that we're not missing something. But I think that Dr. Kiger and his colleagues were actually onto something with this. Now, besides just operating these pumps, there's a few extra things we have to consider. One came from a paper in 2019, which showed that really high hemoglobin levels in large shunts will increase hemolysis risk. And the large shunt thing, made sense to me because if we're continually moving the fluid in a circle, so it goes out of the pump through the oxygenator, but then goes right back into the pump, and only a fraction of it goes to the patient. So let's say you're running it at a liter per minute, but only 100 mLs per minute goes to the patient. You basically have about like 90% recirculation. And that's almost as bad as just running the pumps at low flow rates, just like the CFD data showed. But the striking thing to me was also the hemoglobin levels. So they found that if your hemoglobin was greater than 13 grams per deciliter, you had more hemolysis, both in centrifugal pumps and in roller pumps. And so this, I think, basically is telling us that we need to be cognizant of what we're driving the hemoglobin levels to in these patients. And the reason that I think that this is occurring is because hemoglobin increases the viscosity of fluid. And so shear stress, or the amount of force being applied to a fluid as it moves through any of our devices, is directly proportional to the viscosity. And then the other phenomenon at play, I think, is just probability. So the probability that you would generate a free hemoglobin inducing event within any unit of blood is proportional, or is some relationship to the amount of hemoglobin and the shunt fraction that you have within the system. So the more that we're shunting and the higher the hemoglobin, the better the chance we would have for a red cell to encounter a situation it doesn't like and then likes. And there is some proof of that even in the benchtop. So if you recall, I showed you some pictures from that experiment back in 2014, where you had these arterial line filters that were clogged. And the hematocrit in those tests was over 35%. And if they dropped the hematocrit less than 30% in the same experiments, the filter is no longer clogged. So again, I think Tom and his colleagues were, ahead of the game when it came to understanding what it is that's occurring. So we have, inefficient pumps, but with a high hemoglobin level, give us a recipe for oxygenator clogging. Now, coming back to the study that I had done on our pumps, and I found that the pump type really didn't matter within the circuits. And really what we're seeing was a phenomenon between the 3/8 circuits and the 1/4" circuits. I did see some patients in the 3/8 circuits that still had some problems, but overall, most of those patients were bigger. And so what I looked for was some sort of ratio or a way to quantify how big the circuit was relative to the patient. And so I looked at this, what I call the circuit to patient volume ratio, which is the ratio of how big your ECMO circuit is relative to your circulating blood volume. And I found that as you increased the percent of the circulating volume relative to the patient, that the chances for severe hemolysis or hemolysis greater than 100 milligrams per deciliter would increase. And so basically, once you got over about a 50 to 60% ratio, your chances of having severe hemolysis were much higher. And when I applied this to a model, a multivariate model for hemolysis severity, looking at hemoglobin and blood flow and all of the other parameters, the other two things that actually stuck in the model were this circuit to patient volume ratio and whether they had respiratory or cardiac indications for ECMO, where the respiratory patients were the ones that were more at risk for hemolysis. And so my conclusions from that were that the circuit to patient volume ratio and the respiratory ECLS may denote an inflammatory increase or a higher increase in inflammation, which leads to red cell fragility. So if you look at any literature around the fragility of red cells, you'll find that a lot of diseases will actually cause them to be more fragile. And in anything that raises the inflammatory response in a patient will actually increase the fragility of their red cells. And there's two other phenomenon that sort of reinforced that as far as the fragility goes. And one was a study that looked at this, change from high flow to low flow. So high flows in the black, low flows in the white, and the increase in hemolysis that we were seeing. And if they did it in citrated blood versus heparinized blood, and they found that if you use citrated blood, the hemolysis accompanied by being really inefficient seems to go away. And they found a similar thing, not to the degree between citrated and heparinized blood, but between female and male donor blood, where the female donor blood didn't have as bad of a hemolysis response as the male donor blood did. And so from this, we can again see that it's these two conditions, female blood or citrated blood, seem to increase the fluidity of the red cells, right? So if the red cells are more fluid and less fragile, then they can go through the shear fields, or they can withstand the mechanical stresses that we're imposing upon them without rupturing. And so I think this helps us to understand why we can have two patients side by side, one's doing great and the other one on the same circuit, but for a different reason, is having a more of a hemolytic problem than their neighbor right next door. So given what we know, I think that, we need to start looking at ways to balance all of these things that are going on. So the first way we can sort of work on our balance is we need to reduce operational stresses. We need to improve our pump efficiency. So anytime they're using an adult centrifugal pump, we need to maintain at least 1 to 2 liters per minute going through the pump head with limited shunting, and even maybe home in on these pump specific, flow rate RPM to flow rate ratios. Definitely, I want to keep the hemoglobin less than 12. There's no reason, we deliver enough oxygen as it is. We should not see a big detriment to our patients by trying to keep their hemoglobin below 12. And of course, look at your cannula. Keeping your pressure drops below 100 millimeters of mercury just means it's more gentle. And this is probably more of a thing for the dual lumen cannulas, when the return pressures through the cannulas can exceed 120 much more quickly than you would see like our rule of thumb -40 or -60s on the drainage side. And of course, we need better centrifugal pumps that are actually designed for neonates, because even our PDMAG that we have, its peak flow is about 1.5 to 1.8 liters per minute, and it's inefficient down at the neonatal flow rates. And then the other thing is to improve red cell fragility. Reduce your circuit to patient volume ratios. Try to use circuits that are appropriately sized for your patients. And in the absence of being able to control any of those things, there's actually a drug that's out there that's been around for decades. It's been used in Preterm neonates, it's been used for VAD patients. It's been used on cardiopulmonary bypass, and it's called pentoxifylline. And the way that this drug works is it reduces the drag within the blood. And so then the red cells would experience a more deformable state and reduced into hemolysis. And its original intent was for patients who had aortic stenosis and would have hemolysis because the high shear stress is going through the aortic valve. And so they've, again, reused this in sepsis and in VADs and bypass, and it works really, really well to reduce the fragility of the red cells and improve the free hemoglobin levels. And I think there's a new formulation now that is either FDA approved or about to be FDA approved. That is IV formulation. So it used to be only an oral drug, which you could compound and then inject it IV at each institution. But now there's a new IV formulation that I think will work really well for this patient population. So with that, I'll conclude. I think we've answered any questions that we would ever need to answer about hemolysis, but there is still a lot of work that needs to be done. And I think that continuing to talk amongst each other and at meetings like this about the challenges that we have will further improve our ability to understand what's driving hemolysis and how we can control it. And I'm just looking in the chat. I don't see a lot of questions that are there. So you can find me on the web. I'm also in the ELSO discussion board a lot. So I'm always happy to talk to people and help answer questions about problems that they're seeing clinically. Oh, we do actually have a new question. The question is, are the principles that are used here applicable to adults as well? Yes, they are. So the interesting thing about that 2019 paper that looked at high flow and low flow was the intent of that paper was actually for ECOR. So they were actually looking to see, like, can we use the pumps that we have for ECMO for extracorporeal CO2 removal, which occurs at much lower flow rates. And so the aim of that was for adults. And so we don't see these problems in as adults as much because we run them at much higher flow rates. But if you do have adults that you're running at 1 liter a minute or 2 liters a minute because you don't have good drainage or good flow, you're going to have those problems. And as far as the blood cell fragility is concerned, that actually does apply to adults as well. So when you have lots of donor blood given to a patient, the fragility of that blood's higher. And I said the pentoxifylline has been used in VAD patients, and most of our VAD patients are adults. So adults do see this problem. I don't think it affects them quite as much as far as like increased mortality and things like that, because I think that the relative to the size of the adult, a free hemoglobin of 100 isn't as almost nearly lethal as it is in a baby. But I do see, in adult centers that measure free hemoglobin when they're driving their cardio helps and stuff to, inlet pressures of 400 millimeters of mercury, because they're running at 8 liters a minute or, max flow, that if they measure free hemoglobin, they do have relatively high free hemoglobin, 1,000, milligrams per deciliter or so. But again, it's not causing the sort of multifocal morbidity and mortality that we see in kids. So I hope that answers your question. It is a problem in adults sometimes. It's just not as clinically evident as it is in kids. Another question came in is, what is the first visual sign of hemolysis? And do you rely on lab work? So visually, if you aren't measuring for hemoglobin, which I recommend that everyone does, and so there's lots of different assays out there to measure for hemoglobin. We measure it once a day, and you can send a lab sample down to the lab. Usually we'll spin it down and get the plasma, and then there's a couple of quasi point of care assays that they could do down there, or there's ELISA kits for it. Cal Biochem makes one. A lot of labs actually have their own like homegrown versions of it, because before the Cal Biochem and the point of care one, there really wasn't much commercially available. You can even do a spectrophotometer. There's this CRIPS method, which basically looks at the ratio of absorbance at I think 570 and 540 in the plasma itself to measure for hemoglobin. But if you don't measure it that way, the first thing you probably see is hemoglobinuria. So the urine will turn like a darker pink color. And so typically when you see that, you know that the hemoglobin in the patient's well above 40 or 50 milligrams per deciliter. The other thing clinically that can happen is you start to see blood pressure increases for no reason, because free hemoglobin is a scavenger, and it will basically grab nitric oxide out of the blood. And so nitric oxide, if it's not there, actually will cause vasospasms and things like that. So blood pressure in those patients will go up. There are even studies where they actually injected free hemoglobin into patients that were volunteers, and they also reported abdominal pain or generalized pain as well. So if you have an awake patient that's experiencing a lot of pain, it could be from free hemoglobin. And then David asked, do you think some centers are simply not shunting enough? I think that's probably the case. I think that we were all sold this idea of centrifugal pumps as the next best thing, and we just need to start using them. And we didn't realize really what we didn't know. And so those centers that have adopted them and done well with them and realized that you have to shunt them, probably were the first ones who were using them with adult-sized oxygenators as well. So they had a center that, for whatever reason, to simplify them, we're running everybody with, the adult Quadrox and an adult size pump like a Rotoflow or something. And you can't run an adult Quadrox at neonatal flow rates, because you'll just clot it off in general, because your flow rates aren't high enough. So I think that they took those sort of little nuggets and applied them. And so those centers that were starting to shunt early were experiencing a better outcome, I think, than those that didn't. The other problem I really see is that, not to pick on neonatologists, but to get them to understand that we shouldn't be driving our hemoglobin in these neonates to 14, 15 grams per deciliter. I know that's what they want and that's what they're used to, but when you're on ECMO, you kind of have to do things differently. I fight with my neonatologist all the time about giving bicarb. We do it in the cardiac ICU on 2-day-old babies, and they do just fine. So we should be able to do the same thing in a NICU ECMO patient as well. All right, it looks like our time is up. I thank you everybody for attending. Thank you for your questions. And like I said, I'm easily found online. So feel free to message me or ask questions. And I like hearing from anyone that is interested in this, because I think it's a really fascinating topic.